Hi students, I'm just going to review Chapter 28, Diseases of the Circulatory System. So what I want you to do is go to your ICD-10 CM-PCS Coding Handbook that you used last year and that you are using this year. So I want you to go to Chapter 28 and we're going to start off with rheumatic heart disease. Let's just go over some baseline rules here. Well, first of all, I want you to remember mitral valve stenosis. Whenever you have mitral valve stenosis, you always assume that it's rheumatic in origin. Okay? Now, mitral valve insufficiency, that you do not. Okay, but if I have mitral valve stenosis and insufficiency together, then yes, I assume that it is rheumatic in origin. Aortic's a little bit different. So the aortic valve, whenever that is insufficiency, we never assume for it to be rheumatic. Same thing, aortic valve stenosis. We do not assume it's rheumatic. So even if I put in insufficiency, in the code book, and I have aortic valve, you can see here, your codes are I35. Your I35 codes are non-rheumatic. Now, whenever you mix an aortic valve with a mitral valve, it automatically becomes rheumatic, and those are going to be an I0 number. So again, you can see down here with the mitral valves, it's I0 numbers. So whenever you mix an aortic and mitral valve together, it becomes automatically rheumatic. Whenever you have mitral valve stenosis, you assume that it's rheumatic. Now, insufficiency by itself, you do not. So again, we have mitral valve stenosis and insufficiency. We again are combining stenosis, it's rheumatic. So if we look at exercise 28.1, number 1 is non-rheumatic because it's just regurgitation. 2, since it's mitral valve stenosis, it's rheumatic. Number 3, we are mixing two valves or putting two valves together. Once again, it's rheumatic. Same thing with number 4. It's aortic and mitral, rheumatic. Number 6, we have insufficiency and aortic. Okay, we have mitral and aortic again, rheumatic. And the same thing with number 7. The only time, again, is if you have mitral valve insufficiency, non-rheumatic, and anytime the aortic valve is by itself, it's non-rheumatic. Let's move on to angina pectoris. Okay, this is the next, and what we're talking about is unstable angina, angina pectoris, anything with that. One thing, let's go to where the bottom of the paragraph, it says code I20.0 is designated as principal diagnosis only when the underlying condition is not identified and there's no surgical intervention. So patients with severe coronary arterial sclerosis and unstable angina may be admitted for cardiac bypass surgery or a PTCA. In such case, you'll have a combination code. Okay, you'll have coronary arterial sclerosis with the unstable angina. This can be assigned as principal diagnosis, but if I have unstable angina by itself, then I can have it as principal diagnosis, but if there is another diagnosis with it, that needs to be principal diagnosis. So just something to, remember. They kind of changed the rules on that, stating that there's most times if you have coronary arterial sclerosis, you can add the angina code with it, or it's mixed in with it, I should say. The next big thing is your myocardial infarction. Okay, so when we talk about an MI, it's described as acute or with a duration of 4 weeks or less. We go to category I21. We have an ST elevation, which is a STEMI, and then a non-ST elevation, which is a non-STEMI MI. Your fourth character indicates the wall. Okay, this is very important. I don't like to see the fourth character as a 9. To me, that's unspecified. Okay, so again, if you are coding for inpatient, you should always know what wall that heart attack is occurring at. So again, then your 5th digit is going to indicate the coronary artery, and it's going to go so on from there. So let's go down here to type 1 MIs can also be classified according to whether there's an ST segment elevation or a non-ST elevation. So this is our STEMI, non-STEMI. Again, they share the same pathophysiology, and they're both considered type 1 MIs. So on the next page, I like to point this out to students. If a type 1 NSTEMI evolves to a STEMI, you're going to code it as a STEMI, because of course a STEMI is more, how do you want to say it? It's more, detailed, more serious. But if a STEMI then converts back to a non-STEMI due to a thrombolytic therapy, then you're going to assign the code for the STEMI. Okay, because again, they did have the STEMI. So basically, the STEMI's taken precedence over everything. So STEMI first, then again, that's what you're going to code. Be careful that these codes are used for documented acute MIs, and they should not be confused with abnormal findings on an EKG. Okay, so the other thing here, we have an acute type 2 MI. This can occur secondary to cardiac stress test. With that, we do have a code. It's I21.A1, an MI infarction type 2. A type 3 is when a patient expires from a cardiology or cardiac etiology without a confirmatory cardiac biomarkers. Okay, and then we have a type 4, and you have a type 5. So just review those. Let's go down to when the MI meets the definition of a reportable diagnosis. Codes from category I21 may continue to be reported for the duration, here we go, 4 weeks or 28 days or less from onset. This includes patients who are transferred from the acute care setting to the post-acute care setting within the 4-week time frame. So again, one thing to remember, any encounters after this 4-week time and the patient requires care for the MI, you would assign the appropriate aftercare code rather than that code from I21. Otherwise, you're going to code an old MI. So let's say a patient suffers a new MI within that 4 weeks of acute type 1. A code from category then goes to I22, which is a subsequent STEMI and a non-STEMI, depending on what it is. And then you're going to use it in conjunction with a code from I21. How are we going to sequence it? The I21 and I22 depends on the circumstance of admission. So again, it's like, what are they coming in to be treated for? That's what's going to be first. But again, if it's in that time frame, you are going to have both codes. So just keep in mind that. And make sure you just read down through the examples. I really do feel that, that will help. And also your figure 28.4 is a good decision tree. Okay, just a couple of other things that I kind of want to go through. Heart failure, make sure you read through that. We have heart failure on, just kind of, you're going to have to branch through the chapter. Okay, so we have 2 main types of categories for heart failure, systolic and diastolic. So it's I50.2 and then I50.3. A big one here that we use quite a bit is congestive heart failure, which is basically heart failure unspecified, which is I50.9. So yes, you will be using that quite often. Okay, the next big thing I want to talk about is, let's go to hypertension. You may have to go up a few things. The rest of it should be self-explanatory. I have some things on the worksheet that'll help you with that. But let's talk about hypertension. Okay, if everybody remembers right, hypertension, we start off with the basic I-10. This is our primary essential hypertension. Nothing with it. With I-10, it has to state just hypertension. Okay? Also remember, somebody with elevated blood pressure does not mean that they have hypertension. There's many reasons people's blood pressure goes crazy, and it does not ultimately mean high blood pressure. or hypertension. Also, you have gestational hypertension and you have preeclampsia. Now let's get into I-11. This is hypertensive heart disease. Okay, now we go to I-11. The difference here, we have hypertension. Now I just went to hypertensive. So this takes me to I-11. So hypertensive heart disease is going to be in the I-11 category. Now when I go to a couple of the examples here, they have congestive heart failure due to hypertension. Okay, since it's due to hypertension, they state that that is a relationship, and that's why they're using the I-11. The second example is, it does state hypertensive. Again, congestive heart failure, so that's I-11. Now, the third one, they're also using I-11 because it is congestive heart failure with hypertension. So once again, we are assuming a relationship. Okay, let's go down to hypertension and chronic kidney disease. So this goes to our next step, I-12. One thing to remember with the chronic kidney disease, we're going to use I-12. And then indicate the stage of chronic kidney disease, we'll use the appropriate code from category N18 as a secondary code to identify the stage of chronic kidney disease. It does not include kidney failure. Keep that in mind. Okay, and also it may or may not be hypertensive. The physician indicates a causal relationship. Only the code for hypertensive chronic kidney disease is assigned. I-12.9, hypertensive neuropathy benign, and it kind of goes through the I-12s. Now here, let's look at, they have acute kidney failure with renal papillary necrosis and hypertension. Doesn't say due to for the hypertension. It doesn't say because of or with. It just says and hypertension. So as you can see, they're coding the basic I-10 code with that. Okay, now when we have hypertensive heart disease and chronic kidney disease, this is category I-13. Their combination codes include hypertension, heart disease, and chronic kidney disease. So the inclusion note at the category 113 specifies that the conditions classified to I-11 and I-12 are included together in I-13. So therefore, any patient that has hypertension, they have all three, you should be using I-13 versus 3 different codes. Okay, so to wrap that up, and then we have hypertension with other conditions. So just keep that in mind. When we look at exercise 28.6, we have left heart failure with hypertension. Okay, so that's going to be an I-11 code. Hypertensive, I-11 code. Pretty much all of these on this page are I-11, except number 6. Let's look at number 7. Cerebral thrombosis, and then underneath it, it doesn't say due to and anything like that. We do not assume a relationship. So my code's going to be an I-10. Same thing with number 8. Yes, I have arteriosclerotic cerebrovascular disease, but it doesn't say due to or because of, anything like that. So again, hypertension, it's all by itself, so it's an I-10. Same thing with number 9. But number 10, it says hypertensive, so that takes me to I-11. All right, so I think I'm going to wrap up this video. Hopefully this helps. The only other thing I really want to touch base on real quickly before it stops is your Z codes. Z codes are really important in the circulatory system because they do make a difference on chart coding. So if somebody has a presence of a cardiac pacemaker, you want to code it. If they had bypass surgery, you want to code it. If they have a heart valve, you want to code it. So anything with the heart, basically, for a status code, you want to put on the chart. If anybody has any questions, please contact me.